Welcome to next level ophthalmology. Today we'll be starting the chapter on retina and these will be the topics that will be covered. Today is the first class and we'll be dealing with anatomy and physiology of retina. I would like to begin this class by paying respects to Dr. S.S. Badrinath, founder of Shankar Netralaya, who was a doyen of retinal surgeries in India. And let's move on. So coming to the gross fundoscopic appearance, the retina extends from the optic disc to the ora serrata and has a surface area of around 250 millimeter square. Okay, it is a transparent structure that covers the choroid and it appears red because there is a vascular choroid that is present underneath the retina. Grossly, you can see that the retina can be divided into the optic disc, which is marked by 1 here, the macula lutea, and the peripheral retina. So from the disc, you can see 4 sets of blood vessels arising from the center. And here you can see supratemporal arcade, inferotemporal arcade, supranasal, and infranasal arcades. Usually the arteries and the veins travel together, and the arteries are recognized as they are thinner and lighter, whereas the veins are thicker and darker. So let's understand the parts of macula. Macula or area centralis or posterior pole all mean the same. This is the area that is bounded by the superior and inferior temporal vascular arcades, and the area is around 5.5 millimeters in diameter and corresponds to the central 15 degrees of the visual field. Histologically, it contains a dense network of 2 layers of ganglion cell layer. Then the fovea, which corresponds to around 1.5 mm of the center of the retina and 5 degrees of the visual field. Very important for a crisp visual acuity and color vision. It is seen ophthalmoscopically as a concave central retinal depression, and it contains only cones. There are no rods in fovea. Foveola, on the other hand, is much smaller. It is the avascular zone, so you do not see any blood vessels here. It is only around 300 to 400 microns in diameter. Here, the inner nuclear layer and the ganglion cell layer are absent. There are 2 more important zones called the parafoveal and perifoveal. Parafoveal is 0.5 mm around the fovea, and perifoveal is 1.5 mm around the fovea. Here the retina is thickest as ganglion cell layer, inner nuclear layer and outer plexiform layer, that is the Henle's layer, are thick. So to revise, we studied what is macula lutea or the area centralis, which is 5.5 mm, more concentration of cones, 2 layers of ganglion cells. Then fovea, which is 1.5 mm, corresponds to 5 degree of field, only cones responsible for crisp visual acuity and color vision, seen as a central depression. Fovea is 300 to 400 microns, capillary free zone, absent ganglion cell layer. Umbo is a point which is seen as a bright reflex during a ophthalmoscopy, and then the parafoveal and perifoveal zones. Let's take a question now. The pigment responsible for the appearance of the part of the retina that is marked 5 in the diagram is, so here 5 is marked for the area centralis or the macula. So as the name says, it's macula lutea. So there are pigments of lutein and zeaxanthin in this, which give the brownish appearance to the macula. Okay, there are other pigments also. Let's understand. So these pigments are also present in the macula, but the brown color is attributed to the lutein and zeaxanthin. What is lipofuscin? So lutein is the right answer here. Lipofuscin is a breakdown pigment, that is when photoreceptors are breaking down. These are fluorophores, that is when exposed to particular wavelength, they fluoresce, and that is the principle of autofluorescence. Lipofuscin is increased in cases of Stargardt's disease. Melanin, again, it's present in the RPE cells at the apices of the RPE cells. You can see here melanin granules. So they are responsible for absorbing stray light. Okay, so whenever there is lot of degeneration of RPE, there is excess melanin production. So that is seen as pigment clumps and very commonly seen in disorders like idiopathic macular telangiectasias, ARMD, age-related macular degeneration, or healing of any choroiditis scars. Like if you see scars, you'll always see pigment clumps there. Then rhodopsin or the visual purple, it's a part of rods and it is seen in the photoreceptors. So these three are seen in the RPE, but the rhodopsin is seen in the photoreceptors. So the color of macula is due to the lutein and zeaxanthin. Coming to peripheral retina, it can be divided into near periphery, mid periphery, and far periphery. So near periphery is the 1.5 mm region around the area centralis. So the green here marks the area centralis. So if you take a diameter of around 1.5 mm around it, we get the near periphery. So this much area can be actually seen with the help of an ophthalmoscope. Mid periphery is the area between the near periphery and the equator, or the line, the imaginary line that joins the vortex veins, all the four sides. Then the far periphery is from the equator till the ora serrata, and it is 9.10 mm from the optic disc temporally, nasally, and temporally it is around 16 mm. Then is the ora serrata that marks the beginning of the ciliary body, and it is seen 6 mm from the nasal limbus from the outside. Okay, so 6 mm from the nasal limbus and 7 mm from the temporal limbus. So these are the landmarks for peripheral retina. Moving on to histology, we all know that the retina is made up of 10 layers. Starting from outside, we have the Bruch's membrane, which is the basement membrane of the choriocapillaris. Very tightly adherent to the Bruch's is the RPE, retinal pigment epithelium, which is a monolayer of cells, and they are cuboidal in shape and responsible for integrity of the retina and the photoreceptors. So with the epices, you can see a lot of undulations in the apical border of the RPE. You see this photoreceptors getting attached there. So you can see two types of photoreceptors here. One is cylindrical in shape, and these are the rods. And the ones which have an outer segment which is like a cone, so these are cones. So we have the outer segment of the cones here and the outer segment of the rods. So this is the photoreceptor layer. And then we have a fenestrated membrane through which the processes and the nuclei pass through. So this is known as the ELM, or the external limiting membrane. So mind you, all these layers are visible on something called as an OCT, which I'll be showing you next. So next we have the outer nuclear layer, which is made up of the cell bodies or soma of all the photoreceptors. Then outer plexiform is formed by the connections between the photoreceptors and the bipolar cells. The inner nuclear layers is formed by the nuclei of the bipolar cells, which form the first order neurons. And the inner plexiform is formed by the connections between the bipolar cells and the ganglion cells. In the inner nuclear cells, you can also see other cells known as the Muller cells and the amacrine cells. So these are the amacrine or the horizontal cells. And Muller cells are like pillars that hold the green ones are the Muller cells. So which are pillars of connecting the inner and the outer retina. If you see, they extend right away from the inner nuclear layer to the inner limiting membrane to the external limiting membrane. Then we have a layer of ganglion cell layers, which we discussed. They are absent in the fovea. And then there is the nerve fiber layer, and the innermost is the internal limiting membrane, which is in close approximation with the anterior vitreous face. So these are the 10 layers, which can also be seen on OCT. So internal limiting membrane. Then here the bright one is the nerve fiber layer. Then this is the ganglion cell layer here. If you can see, it's absent here. This is the fovea. It's absent here. It is very thick here and it's absent here. Then you have the inner nuclear layer. Inner plexiform layer, the inner nuclear layer, the outer plexiform layer, outer nuclear layer. Okay, and here you have something known as the external limiting membrane. Okay, so this line is the external limiting membrane, which is followed by a hyporeflective myoid layer. Then there is a hyperreflective ellipsoid layer. Ellipsoid layer is formed by the outer segments of the photoreceptors, which are metabolically very active. So if you see here, the layers appear black, white, gray, white. So the ones which are more white are referred to as hyperreflective areas, and the ones which are a little dark are referred to as the hyporeflective zones. So whichever layer has more of fibers and connections appear bright. Whichever layers have more of nuclei and soma, they appear darker. So that's why you get inner nuclear and outer nuclear layers that appear hyporeflective, whereas the plexiform layers appear hyperreflective. The outer retinal blood retinal barrier is constituted by tight junctions between the cells of vascular endothelium of retinal capillaries, photoreceptors, axons of the retina, and retinal pigment epithelium. So the important function of RPE is to maintain an outer blood retinal barrier. So blood retinal barrier is important to protect the integrity of retina against drugs and toxins. So the inner retinal blood retinal barrier is formed by the vascular endothelium of the retinal capillaries, as you can see here. So outer retinal barrier is formed by the RPE. So that is formed by the tight junctions that is present between the cells. So to understand various spaces, there is a subretinal space. So when someone says subretinal, it doesn't mean below all the retinal layers. So we always refer to as up till the layer of photoreceptors, we refer to as the neurosensory retina. And the RPE is considered phylogenetically different because it arises from a different part of the germ layer. So till neurosensory retina, we consider it as one unit. And when you say retinal detachment or a subretinal fluid, we mean that the fluid or detachment is between the neurosensory and the RPE. So this is the bright line is the RPE. So this is a neurosensory detachment, and if this becomes a very big one, you can call it a retinal detachment. So what is an sub-RPE space? You can see that the RPE is elevated here. So this is known as an RPE detachment, okay, or pigment epithelial detachment, also known as PED. So these are various conditions we'll discuss later. Then something below the choroid and between the sclera and the choroid is known as the suprachoroidal space. Let's move on to the differences between photoreceptors. We have a rod and a cone. Rod is called a rod because its outer segment is shaped like a cylinder, and cone is named so because its outer segment looks like a triangle. So there are a few differences between the two. Rods are more numerous. There are around 120 million rods, whereas the cones are few. Each of them has a role of its own. Okay, the location of rods is more outside the macula. Cones are more concentrated in the macula. Pigments, the pigment present in rods is called rhodopsin, whereas the pigment present in cone is called iodopsin. So rods are more sensitive to dark or dim illumination, whereas cones are very sensitive to bright illumination. The shape of the outer segment we have already discussed. The number of mitochondria in rods are lesser compared to the mitochondria in cones. There is only one type of rod, but there are three types of cones called the S cone, N cone, and the L cone. S is for small, that's for small wavelength, and it represents blue. N represents green, and L is for large, which represents red. So each for a primary color. Sensitivity is very high for rods, in the sense any drop in luminescence, the rods get activated, but sensitivity is very low for cones. So you need a very bright light to stimulate the cones, but you need a little bit minimal light, or the light minimum, which is the minimum amount of light that is necessary to stimulate a cone. Connections: multiple rods to one bipolar cell. whereas one-to-one connection with bipolar cells is seen in cones. So when there is one-to-one connection, there is increased specificity, or the image formation is much more clearer with cones. So cones are responsible for sharp visual acuity and color vision. Rods are responsible for night vision and appreciation of movement. So coming to the structure of macula, when compared to the rest of the retina, we know that macula has more number of cones. The cones present here are longer, and then there are photoreceptor bipolar cell correspondence, which is more one-to-one. The RPE are taller, and there is increased pigmentation. There is a lot of xanthophyll that is present, a pigment that is helpful in absorbing UV light. Then there are multiple ganglion cell layers, very thick layer, which is also, we spoke about it before. And the OPL, or the outer plexiform layer, is obliquely arranged and is also known as the Henle's layer. So these are the histological differences between the cells of macula and the rest of the retina. Let's move on to fundoscopy, a more practical topic. So fundoscopy is nothing but viewing of the retina or the posterior segment of the eye. It's also known as ophthalmoscopy. Do not confuse with retinoscopy. Retinoscopy is an art of understanding the refractive status of the eye. It's a part of objective refraction. So retinoscopy and fundoscopy are two different things. So this can be performed by using a direct ophthalmoscope. By slit lamp biomicroscopy, if you can see, the doctor here is holding a condensing lens known as a 78 diopter or 90 diopter lens. Or you can even do it by indirect ophthalmoscopy. So what are the differences between direct and indirect ophthalmoscopy? The field of view is smaller in direct ophthalmoscopy, whereas in indirect you get a very large field. It's 40 to 45 degrees. The need of condensing lens, no, but you need a condensing lens either 78D or 90D or a 20D or a 30D. Indirect, we here include both slit lamp and the indirect ophthalmoscope. There is, for a refractive error of the patient, you have to do some adjustments within the direct ophthalmoscope, which is not necessary in indirect ophthalmoscope. Here, this is an important point you should know. The image formed is erect and virtual, and there is no confusion regarding lateral or vertical inversion. But in indirect ophthalmoscopy, the image formed is real and inverted both laterally and vertically. The size of the image is 15 times in magnified, but here it's just 1.5. The image appears small, but the field of view is big. So if you want greater detail of the disc and macula, you choose direct ophthalmoscope. If you want to see the whole retina in a go, you choose indirect ophthalmoscope. So both are complementary to each other. Because you use only one eye to view the retina in direct ophthalmoscope, binocularity and stereopsis, that is 3D vision, is less or absent. Here it is present. Measuring the depth and elevation is possible using, we have some scales there. You can turn the knobs of the direct ophthalmoscope and measure the depth and elevation, which is not possible in indirect. You can't measure. You can appreciate it is deep or elevated, but you cannot measure it objectively. The working distance is very small in direct ophthalmoscopy, whereas in indirect, it is bigger. Then mastering the skill is easier in direct ophthalmoscope, but it takes a little time in indirect ophthalmoscopy. An important difference is viewing the macula, viewing the retina in a difficult or a hazy media is very difficult because the illumination is not that bright. But in indirect, it is easier. What is the best method to screen for diabetic retinopathy? Is it direct ophthalmoscopy in a mid-dilated pupil, direct ophthalmoscopy in a dilated pupil, indirect ophthalmoscopy with 20 diopter lens, or slit lamp biomicroscopy? So the answer here is D. Slit lamp biomicroscopy with a 78 or 90D lens gives you stereoscopic vision, a good look at the macula, because that's where the disease actually begins in diabetic retinopathy. Also, to appreciate the very tiny new vessels, it is best done with a slit lamp biomicroscopy with 78D or a 90D lens in a dilated pupil. So this is something known as an Amsler-Dubois chart. which is used to draw retinal drawings. So here we have marked equator and 3 circles around it. So each circle represents equator, ora serrata and pars plana. Then you can draw the optic nerve according to which eye you are drawing. If suppose you're drawing the left eye, you draw the optic nerve to the left of the macula and use these color coding for drawing the lesions. Suppose you are drawing blood vessels, hemorrhages, attached retina, vascular tumors, you color them in red like that. If you're drawing detached retina, veins, outlines, retinal breaks, you use blue. Intraocular foreign body, IOL, which is hemorrhage membranes, are all colored in green. Uveal tissue, nevi, melanoma, pigment epithelium detachment, and any choroidal detachments are colored in brown. Exudates, any pus, any retinitis, drusen, gliosis, all those are marked in yellow. Whereas laser marks, sheathed vessels, pigments, and edges of the scleral buckle are marked in black. So this is how you color code your retinal drawings. Moving on to blood supply. The blood supply of the eye is derived from the terminal branch of the internal carotid, which is ophthalmic artery. From the ophthalmic artery, you would see posterior ciliary arteries arising, and after that, the central retinal artery arises from the ophthalmic trunk, which pierces the optic nerve and enters the optic nerve around 1 to 1.5 centimeter behind the lamina cribrosa. After entering the lamina cribrosa through the optic nerve head, it bifurcates into two and then dichotomously branches into multiple segments, that is always accompanied by the central retinal vein. And these further divide and form retinal capillaries, which form the dense capillary network in two layers. One will be in the ganglion cell layer, the other will be in the inner nuclear layer. Okay, so the inner retina till the inner nuclear layer is supplied by the retinal circulation, whereas the outer retinal circulation, retinal perfusion is formed by the choriocapillaries. Okay, so here you have a watershed zone. So what is different about the blood supply of the retina? These blood vessels have autoregulation that is present also in brain and kidney. In the sense, whenever there is increase in blood pressure or hypoxia, these vessels have the ability to regulate the amount of blood flow to the retina and it's never compromised. So this is the basis of seeing features of hypertensive retinopathy, in which you see the vessels are constricted. In cases of severe hypoxia, like in severe diabetic retinopathy, you'll see that the vessels are dilated because they want to bring in more oxygen to the tissues. So the capillaries have endothelial cells and they have a basement membrane, and they have a protective layer of pericytes, which are like amoeboid cells which can take any shape to cover up the basement membrane and prevent leakage. There are tight junctions present between the endothelial cells which form the inner BRB, which we have already discussed. The retinal capillaries supply the inner two-thirds of retina. We have again discussed this. They lie in the inner nuclear and the ganglion cell layers. In the macula, there are 4 layers and they are much denser. The parts of the retina that are free of capillaries is the perivascular areas and the foveal avascular zone, which is also known as the foveola. Okay. Let's move on to the physiology part of it. Photochemistry or photo transduction is a process by which electric currents are produced in the retina following exposure to light. So what happens when there is exposure to light? So this is a dark adapted eye and suddenly there is entry of some flux of light into the eye. The rhodopsin is in combination with the cis part of the vitamin A. Retinal or retinaldehyde is a form of vitamin A which is in contact or which is in close proximity to the visual purple. On exposure to energy, there are some conformational changes that occur that lead to the formation of metarhodopsin through various steps. So this metarhodopsin is an active component here which is responsible for phototransduction. During this process, the opsin is released from the visual the combination is broken and the retinal comes out as the all trans form. Okay, so the all trans form cannot combine with the opsin. Okay. Now the meta-rhodopsin that is there will cause some changes in the outer segment of the photoreceptors, that is the rods, leading to the stoppage or cessation of exit of sodium ions, causing hyperpolarization. As a result of this, electrotonic conduction is set up, which forms the basis of formation of electric currents that are later transmitted through the optic nerve, optic chiasm, tract, and finally the visual cortex. So this is the way phototransduction occurs. So later what happens to this? The all-trans retinal is quickly converted with the help of isomerase to a cis-retinal component, which again combines with the scotopsin to form the inactive part, which is the rhodopsin. So this is known as rhodopsin regeneration. So this is a visual cycle that happens when every time light enters the eye. A 56-year-old man presents with nyctalopia of 4 months duration. On examination, he is icteric and has a distended abdomen. On investigating, his liver function tests are grossly deranged. Which component is responsible for this symptom? So here we are talking about nyctalopia or night blindness. Night blindness doesn't mean he has problem only in the night. It means that he has a problem in dim illumination. This is an old terminology. You should not get confused. A problem in dim illumination is because of dysfunction of the rods. So rods need a lot of vitamin A, which is probably missing in this. So vitamin A deficiency here is caused by a severely deranged liver due to probably alcohol. So which component is responsible for this symptom? Increased bilirubin. Bilirubin has nothing got to do with the visual cycle. So do aminotransferases. Albumin, you might have a doubt because there is a retinol binding protein that transports the retinol from the blood, the liver, to the retina, but it is not albumin. So the right answer here is retinol. So decreased retinoic acid or retinol is the cause for this nyctalopia in this patient with chronic liver disease. So vitamin A deficiency does not always follow malnutrition. It can also follow liver disorders. Moving on to light adaptation and dark adaptation. Light adaptation is when dark adaptation is when a person moves from a bright light to dark light when the rods become active. So it is a slow process. Light adaptation is the reverse, when you move from dark place to a bright place where the cones get activated. So always there is an interplay between the rods and cones, and the retinal sensitivity keeps on going up and down to maintain a proper visual sensation. So what happens in dark adaptation? When an individual enters a dimly lit room from a brightly lit area, he finds it a little difficult in the initial period, and after following the time of dark adaptation, that is around 20 to 25 minutes, the visual acuity improves. So the increase in sensitivity with time due to activation of rods is known as dark adaptation. So you can plot the dark adaptation curve by illuminating a portion of the retina that has both rods and cones, that is around 11 degrees from the fovea. So this is used primarily to detect rod dysfunction. So what is the dark adaptation curve? In here we plot the sensitivity of the rods and cones as against the time. If you see, there are two parts of the curve. The initial shorter but quicker curve is formed by the cones. So initially they are excited faster. The cones are very quick, but they do not last long. So after a point, the sensitivity of the cones do not improve, but the rods become more and more sensitive. It's said that the sensitivity increases by around 20,000 times. So they are able to detect even very low threshold. So that is known as the light minimum. So this break is known as the rod cone break or the alpha point. So this is how a dark adaptation curve looks. So what happens in light adaptation? It is a faster phenomenon. It's just a reversal of dark adaptation. And the sensitivity of the retina decreases due to pigment bleaching. The retina doesn't have to be as sensitive. So all the cones are active in light adaptation. So dark adoptometry is a visual psychophysical test that assesses the sensitivity of the photoreceptors and the time required for the adaptation to darkness. So increased dark adaptation time is seen in vitamin A and rod degeneration. So based on this, you can understand that we have photopic vision, which is vision in bright light. Here on the cones are active and you get good color vision in photopic vision. Mesopic is where both rods and cones are active, and most of our examinations should be done in this illumination. Scotopic vision is when the luminescence is below 0.03 candela per meter square, and this is more of a function of rods. Coming to color vision. Color vision is the ability of the eye to differentiate various colors as excited by light of various wavelengths. So we have the most heard of theory, that is the Young and Helmholtz trichromatic theory, which says that there are three types of cone receptors which are responsible for each primary color, that is red, blue and green. So a mixture of all these three colors gives you the sensation of colors around it. Whereas the opponent color says that there are two colors which are mutually exclusive. So when there is increased absorption of red, green is seen. When there is increased absorption of green, red is seen. So there is no color that is reddish green or bluish yellow or blackish white. So each of these theories has a different place in different settings. And then there is Granit's polychromatic theory that says that there are around 7 types of cones that are responsible for the 7 rainbow colors. So what are the tests for color vision? Ishihara pseudo-isochromatic charts, Hardy-Rand-Littler charts. Again, these are pseudo-isochromatic charts. Holmgren's wool test, Farnsworth-Munsell test, and Nagel's anomalouscope. So color blindness or dyschromatopsia is a condition in which individuals who can perceive all 3 primary colors is not happening. So a person who can perceive all 3 colors is called a trichromate. So any one of the colors is defective is termed as a dyschromatopsia. So in color blindness, we can have partial or complete. Partial is when he can see all the 3 colors, but one of the colors he is not able to perceive well. So based on that, we call it as anopsia, which is protanopsia, or deuteranopsia, or tritanopsia. Anopia is total absence of a particular color. So the genes present for the blue sensitive cones are on the chromosome 7, whereas the red and green cones are seen on the long arm of chromosome X. So anomalous trichromates is mild color blindness, which is they can perceive all the 3 colors, but it is defective in 1 or 2. So protanomaly cannot perceive red well, deuteranomalies cannot perceive green well, and tritanomalies cannot perceive blue. So when you say dichromatic vision, the person can have only 2 colors that can be appreciated. So protanopias cannot perceive red at all. So he uses red and green and blue. Deuteranopias cannot perceive green, and tritanopias he cannot perceive blue. Which type of congenital color blindness is associated with nystagmus? So what you should know about color blindness is the persons who have color blindness. I won't say patients because it's you cannot term it as disease. It is an inability. So they perceive colors in different shades of gray. So if you show them purple, they will know it is purple, because their brain has been taught that that particular shade of gray is purple from childhood. They will not realize that they have color blindness unless you perform the Ishihara pseudo-isochromatic chart. But they have good visual acuity and they can see very well. So, but there are a few types of very rare types of color blindness that is associated with poor cone function. So this is known as rod monochromatism, in which the cones are totally absent and the cones cannot perceive colors at all. So they have a low vision around 660 to 624, and they have a nystagmus. So this rod monochromatism is a type of color blindness which has low vision. So understanding the differences between congenital color blindness and acquired color blindness. Congenital color blindness is asymptomatic, like I explained to you. Acquired may be symptomatic. They may see one eye worse than the other. It can be unilateral or asymmetric. Whereas color blindness, congenital one is bilateral and symmetric. Congenital color blindness is seen more in men, but no such gender predilection is seen in acquired. In congenital, the red-green is most commonly encountered, whereas in acquired, you can have blue blindness in macular disorders and red-green issues in optic nerve disorders. Ocular findings, visual acuity is usually normal, whereas visual acuity can be subnormal in acquired color blindness because here the pathology is there in macula or the optic nerve. Fundus findings are usually normal in congenital, whereas it is abnormal. You can see some abnormal fundus findings in the acquired color blindness. Natural history, it's a stationary and a permanent condition. Acquired color blindness may progress or improve depending on what has caused the color blindness. So the tests usually useful here are the Ishihara and the HRR charts, whereas Farnsworth-Munsell and Naegele's anomaliscope are more useful in acquired color blindness. Choose the test that is based on the principle of pseudo-isochromatism. So here, pseudo-isochromatism means false appearance of same colors. So in Ishihara chart, if you have a look at it, it's based on, confusing the individual with colors of similar hues. So a dark green is placed next to a light green and a different shade of green is placed to that. So the patient will all perceive these as same color and he won't be able to recognize the pattern within the chart. So this phenomena is known as pseudo-isochromatism, and this is what is used in Ishihara's chart. This is the best test you can use to detect congenital color blindness. So that's all for today. Let's meet at the next class. Hope you learned something. Thank you.